You are listening to Medical Imaging Matters, a podcast from AHRA, the Association for Medical Imaging Management. Tune in as we dive into the stories, the trends, and the best practices that matter most to you, the medical imaging community. Today's episode is sponsored by Aidoc. Aidoc is at the forefront of clinical AI, empowering healthcare teams with the right information at the right time to enable quicker diagnoses and better patient outcomes. Powered by the Aidoc AIOS platform, Aidoc's AI works seamlessly behind the scenes, ensuring no patients fall through the cracks while allowing clinicians to focus on what matters most. Aidoc and AI are not just the future of healthcare, they're changing how healthcare is practiced today. As an example, Aidoc, in partnership with AHRA, is pleased to bring you this podcast featuring Dr. McKinney and Dr. Jose from the University of Miami, two leading experts in medical imaging AI. They will share how AI is transforming workflows in one of their outpatient centers and helping to identify patients who need acute care before they even leave the facility. Join us for their insights into the future of radiology and the profound impact AI is having on clinical practice. Hello, my name is Jason Newmark, and I'm the Executive Director for AHRA, the Association for Medical Imaging Management. And I'm very excited to facilitate today's episode of our AHRA Medical Imaging Matters podcast series. I have to admit, it's a Friday morning before a long weekend, so that might be why I'm excited. But I'm also excited because today's topic is one that literally is one of the most prevalent topics presented on, discussed, inquired about by all of our AHRA members on the online forums and our in-person events, you name it. It's also a topic that continues to be consistently addressed in pretty much every medical imaging management journal you'll read, in clinical journals, at association meetings, not to mention in non-healthcare arenas on TV commercials and even more. So today's topic will be around artificial intelligence or AI. Now, I have to admit also, for someone growing up in the 70s, the 80s, it makes me think about Star Wars, Star Trek, all the movies projecting about how AI would rule the world in the future or today. And I'd love to sit back and talk about those movies or dive deeper into the world of Skynet from Terminator. But honestly, for those of you maybe old enough to remember this quote from HAL 9000 back in 2001, A Space Odyssey, I'm sorry, Dave and listeners, but I'm afraid I can't do that. Rather, today we're going to focus on AI in our world, the world of imaging. And specifically, we're going to focus on AI-driven workflows and how they are elevating patient-centric care and maximizing value in radiology. So today, during our discussion, we're not going to hear conceptual value of AI or what it might be able to do. What I'm excited about is that we're going to hear real-life, real-world examples of how one organization is truly utilizing AI today to realize these enhanced workflows, improve their patient care, and optimize staff efficiencies. And these are all critical areas of focus for anyone in the medical imaging management field or clinical field today. So with me today to share specific examples of their AI value journey, I'm pleased to introduce two leading radiologists from the University of Miami Miller School of Medicine in Miami, Florida. We have Dr. Alexander McKinney, the chair and professor of the Department of Radiology, and Dr. Jean Jose, professor of radiology and the associate vice chair of IT. Doctors, welcome.
Thank you.
Good morning.
All right, so to get us started, maybe Dr. McKinney, you can provide an overview of just the University of Miami, the radiology department, the size and scale and scope of the services. I think it will resonate well with our members and listeners.
Yeah, thank you for having us, Jason. I started here almost 5 years ago, and we've grown to be almost doubling in size or more of radiologists, over 1 million exams. And, post-COVID, there's been this extreme growth in radiology, and growth of exams across the country that's going to progress to be doubling over the next 10 years. So with that in mind, I'm in this podcast thinking how I'm going to use AI to help us deal with that, because we grew faster than expected post-COVID, and now we're going to grow even faster. And that's happening across the country. Unparalleled growth in imaging.
I completely agree. And that's why I mentioned that our members are constantly looking for ways to find new efficiencies. How do you do more with less? How do you optimize those workflows? So I'm super excited to kind of hear your story. And maybe to get us started, you could walk us through sort of how University of Miami, delved into the AI space, and sort of were there certain challenges you were looking to address or certain things that came up that you said, this is our time and this is our chance to go and get approval and bring AI into our workflows?
Yeah, thanks for asking. So the first premise in mind is the background of what's going on, with the workforce of radiologists themselves and the growth of exams I just talked about. So we just discussed about how there will be a near doubling or doubling over the next 10 years, 14% compounded annual growth rate of imaging by the year 2034. And I have this 50% rule for radiologists, right? 50% in burnout right now. 50% have changed their jobs in the past 5 years, and we've lost about 50% of our professional fee reimbursement in the past 10 years. So we don't want to create a situation where we burn them out further. So, how can AI help us? So, my lead into this discussion is essentially that it has to help us work smarter, faster, with higher quality, but be patient centric and get to patients to where they need to be and with the more urgent findings essentially finalized, but also to where they need to be faster, like referred to their appointments, their follow up imaging, etc. So, it needs to be more patient centric and radiologist
Right.
centric at the same time.
Right. I completely agree with you. And I think what's most interesting to me is just trying to understand, AI has been out there for several years. I remember RSNA a couple of years ago, it was the major theme, and everyone was talking about AI, it's going to solve all our challenges and this, that. And it was, like I said earlier, it was more conceptual. So I'm really excited to hear kind of how you guys have used AI to really start to see some value and to make some impact on all of the things you mentioned. Was there something specifically? I mean, was it so basically you said it was driven by the staffing shortages and the volumes increasing at exponential rates? Those were sort of the cornerstones of what drove Miami to sort of look to the AI solutions.
Yeah, I mean, essentially, some of the use cases were that we call it like they use different words, but one thing might be called the prioritization advantage, or basically how quickly a positive finding is identified and the patient is moved along the care pathway. And one of our use cases was incidental pulmonary embolism, for example. We are
Mhm.
finding about 1% of our patients because it's like a 10 to 50 times higher rate of incidental pulmonary embolism, lung clots in patients that have oncology. We have over 50% oncology patients. And so what we were finding is these people would show up to the clinic. And with those, with having low staffing, high volume, we were worried that those outpatient films, not necessarily inpatients, we had good turnaround times, but outpatient films having things like lung clots would sit around too long, their disposition could get worse, right? So we wanted to make sure those were prioritized to the top of the reading list. And so that's one of the reasons we looked for value in identifying patients with potentially life-threatening diseases earlier in outpatients, and we've moved this now to other areas outside of lung clots. And I mean, and maybe I could turn it over to Dr. Jose for the boots on the ground deployment of that. But we noticed that the buy-in from physicians using communication apps, seeing the findings, the patients going from straight from the outpatient clinic, which I'll let Dr. Jose describe a bit, and knowing that, hey, you know what, before you leave today, we found out you incidentally have a lung clot. Here, here's what you need to do. Worst case scenario, only a small minority emergency room. Most of them would be followed, put on anti-clot medicines, etc. So if you, I don't know if you mind, Jason, maybe Dr. Jose can talk about the utility of that type of example of use cases where we're identifying people earlier. They're happy. The referring providers are happy. We're happier that we're not letting people walk out the door with a serious condition.
Yeah, absolutely. So, good morning, everyone, and thank you again for having us share our experiences. We've really been very fortunate to not only be under the lead of Dr. McKinney and his vision, but also since we are the largest academic health center in South Florida, and as Dr. McKinney mentioned, we've had exponential population growth. But the main accelerator, Jason, in my opinion, as to why AI implementation has accelerated drastically over the past 3, 4 years has been the pandemic. It's a similar situation that other large institutions have faced where the social distancing pushed us to implement telemedicine and a heavier reliance on imaging. So to Dr. McKinney's point, during the pandemic and after, we had a confluence of events. We have a very large oncologic population. Our clinicians were seeing more and more patients via telehealth. We've also had expanded roles of advanced providers, which also relied more heavily on imaging. And so that confluence of increased volumes required for us to impact our community positively. And one of the best ways was to accelerate the triaging of positive or critical cases. And to that end, we also had to find innovative solutions to deal with this. And one of the ways we dealt with these critical findings was by implementing the human aspect of it. What Dr. McKinney has termed the human intervention. And that's really critical for us. It's transformed the way that we practice imaging at the University of Miami. And I think it serves in a way as a model for future deployment of similar solutions at other large institutions. And what we mean by human intervention and what we found with the deployment of AI at the core is that definitely AI will not be replacing anyone's jobs. That is a horrible misconception that we're trying to educate the population at large. But in reality, it's an augmentation and it's empowering and creating new roles for our human force. And that's been something that's extremely exciting for us. And because AI has allowed us to identify patients with potential critical findings earlier before they leave our department, our innovative workflow using human intervention has resulted in drastic improvements in how we practice, not only from a decrease in turnaround times for those critical findings and communication of those critical findings to the referring providers, but also patient satisfaction. It's brought the radiologist to the forefront. We are engaging directly with patients, and they are in turn being extremely appreciative because the imaging staff somehow was able to fill the gap. That separation that I was talking about earlier that was caused by the pandemic and social distancing, the reliance on telemedicine, well, the imaging department and the imaging team has helped bridge that because we are patient forward and patient facing. So that has resulted in really positive patient outcomes on different metrics, including press gaining. The fact that an imaging staff member is interacting with the patient, discussing their imaging results at the point of care and with their family members, the feedback that we've gotten back has been overwhelming. And that has been, in my opinion, one of the biggest positive surprises that we've had at the University of Miami with the implementation of AI.
Right. And those sound just like fantastic value adds and points that maybe some of our listeners and even myself wouldn't have thought of, right? We always think of, like you said, a misconception that AI is going to replace someone's job, or AI is going to, make it that you don't need certain people doing certain functions, where I think what you're driving at is that it's enabled you to, I think the words you used was to find things earlier and engage with patients and your staff and sort of your diagnostic work in a completely different way. So I'd love to dive into that in more detail. But right before we do that, I just want to step aside here for a moment. So wearing my administrator hat, I know one of the biggest challenges that a lot of us faced was working with our clinical leaders, such as yourselves, to convince an organization to actually invest the dollars in AI, right? Because a lot of it was those misperceptions or the promises of what AI might be able to do. Can you guys just share for a moment, just sort of, as you delved into the, your search and assessment of different AI capabilities out there, how did you go about working with the administrators at your hospital to sort of gain their buy-in and sort of gain their supports that you could find the capital, the resources, and the time required just to implement it and bring it into play? I'm just curious if you have any perspectives on that.
That's a really good and long answered question that would fill books and maybe tomes, right? So I'll give you this short version. There are, I don't know how many AI vendors, I can't count them anymore, right? And I think the unfortunate thing, or most, are what we use the word, that's been used to some detriment, which is, pixel based. And the problem is, if you look at the average solution that costs, $50, $80, $100,000 a year to implement, based on your number of users, there's a lot of other factors, right? Software as a service, usually. The problem is you have thousands of potential disorders, Jason, that you can try to identify on imaging, depending on the body part. Right. And you can't pay for tens of thousands of disorders for all these different body parts, $50, $100,000 or whatever it is a pop, right, for all these different users. And so it becomes tens and hundreds of millions. You wouldn't be able to afford it in a radiology department, right? You just can't afford it. So you go to and I think Dr. Jose and I described earlier what we call our point of care AI deployment, right? That we call POCAD, which is you talk to the administrators and you say, and you get a buy-in and say, what is the problem we want to solve? The administrators articulated to me, and I articulated them in our instance, that we really want to detect what these patients are at risk for in our oncology patients. First, when they come into the emergency room or as inpatients, what other things could they have besides what we know that they have? And there's many other things, as you know, oncology patients or those being worked up for oncology can have, right? And then as outpatients, what are they at risk for? Let's start with those conditions, right? Because the things that are very easy for radiologists to see, right, we're not so much worried about the misses and that replacement. I mean, there's a lot of legal reasons, AI can't replace radiologists. It's called learning intermediary standard, and that's a topic for another day. But what you really want to use AI to do is to help the patients and get them to where they need to go faster, as we said earlier, right? So that discussion is, well, what is the value, right? And we're probably going to hear this word later. What is the value? Well, the value would be detect patients earlier. The value would be that when we find these positive findings in inpatients or in the observation or the emergency room, there's a decreased length of stay, right? In observation or in the emergency room, et cetera. We can go on and on with, the various metrics, there's patient satisfaction metrics. I think that's one thing radiology and radiology administrators haven't done, or radiologists and radiology administrators haven't done, is we really haven't looked at those non-kind of image-based metrics, right? And now we can start to pair what we're doing with clinical metrics that many of these various metrics, whether it's the Vizient, the Press Ganey, US News World Report, et cetera, right? We could start to pair radiology with some of these things, and AI can help us do that, not just on the image-based pixel AI, which can be expensive, right? But also on accessing other parts of the data records.
Right. Well, I think you just hit on some things that, I'm excited to dive in again a little bit deeper, but wearing that administrator hat, oftentimes you'll get caught up in the funding, right? Funding is difficult and the financial challenges, or we don't have enough resources to implement. But I think what I heard you say and what's resonating with me is the way you can get to buy-in is to say, listen, we're going to focus on what we're here for primarily, which is patient care. So if we can do earlier diagnoses, we can help. That's going to engage our patients. It's going to help us make better diagnostic decisions and care plan treatments. We're going to reduce length of stay. And in return, that's more satisfaction from the patients. You have more engagement. You're actually reducing expenses if you can move people through the system quicker. It actually might add revenue if it's adding additional tests or additional testing that's appropriate, of course. I get really excited about that. I think it's an interesting way for our listeners to be thinking about when they look at AI and are trying to gain buy-in. It's not all about the financials. And I think this patient-centered, patient care type of dialogue that we're having now is what really drives the decisions. So I'm excited if you guys, we talked a little bit about it in our preparation for the call of just understanding more about exactly how you guys rolled that out and diving a little bit deeper into how you're using it in the oncology world and how you're using it specifically. I'll also say I like that you guys focus, because you could boil the ocean with AI, right? And I think people get lost, and that's why maybe you don't hear as many success stories. People try to use it for everything all at once. I like that you focused in on one or two areas and have really started to see that value. So maybe between you and Dr. Jose, we dive into that even a little bit deeper, and you can kind of walk us through, I think, just how you've been elevating that patient care and the workflows you've changed. I think that'd be fantastic.
I'll turn it over to Dr. Jose. I would say at a larger level, we first do the curation of the algorithm, which I can't emphasize enough. Whatever company, vendor you're working with, you have a partnership, you should have trust, right? And they have to have a willingness to accept potential holes or loopholes that they have in their program and to work on their own accuracy and the use cases, et cetera. While you're doing that curation, you're figuring out your workflow. As a matter of fact, you should have thought about your workflow with the various partners, multidisciplinary collaboration, right? So whether it's pulmonology in our case and the neurosurgery service, when you talk about brain aneurysm, so forth and so on, neurologists, you have stroke, you have so many different services. And so the workflow is not exactly the same for each of these services. So when Dr. Jose talked about what we call HI, or the human intervention, right? The human interfacing component, right? You figure out the workflows and who's going to be talking to who about these findings, right? So part of it is not just the imaging-based AI, which seems to get the most press, but actually the more interesting, quite frankly, the part that is harder to figure out, but will certainly make a radiologist's life and also the other physicians' lives easier, referring providers easier, is how that human workflow, communication, disposition, transfer, et cetera, patients happen. And at this point, I'm going to turn over to Dr. Jose, because he can really, tell you working examples and why that's so critical. Because if you adopt AI and you have nothing to digest AI, then your mouth just becomes bigger than your stomach, in my opinion.
That's exactly right. And Jason, to your earlier question and point, how to get buy-in, it's first communication and education. And it starts, again, as Dr. McKinney mentioned, not only educating the administrators on what the algorithms can do, but broadening their minds to understand what really the deployment of that algorithm is going to mean to the institution. And more importantly, what kind of support the institution is going to need to successfully launch and maintain that algorithm. And that part of it, that education part, that communication part, that frankly Dr. McKinney does an excellent job in doing is having them look beyond just the FDA clearance for the algorithm, but more so having administrators and our referring clinicians understand the implications of turning on this algorithm is super important for the successful deployment and the overall outcome of the algorithm. So that's number one. The other really important thing for us, and together with our vice chair of IT, Dr. Tiago Braga, we came up with a common language. It turns out that, and the American College of Radiology is working on this, but it turns out that a lot of the misconceptions and misunderstandings arose from a lack of common definition. So we had to develop our own quote unquote internal categories where we prioritized depending on our needs on how we were going to define what impact these algorithms were going to do to our patient population. So we started off categorizing the acuteness and the criticality and the incidentalness of the AI generated findings. And based on those, we created a list of requirements or support that we needed per category to successfully implement the algorithm. So for example, if I have an algorithm that will prioritize a study based on a very critical finding, let's say pulmonary embolism, and let's say that algorithm is detecting that critical finding in an incidental manner, meaning that it is not something that that study was originally ordered for, and it's not something that the referring provider, the ordering provider, or the patient was expecting to find. Well, that adds a certain level of complexity to that particular critical finding that needs to be addressed, as opposed to perhaps another finding that is not critical, but also perhaps unexpected, where we are also obliged to convey that information both to the patient and also to the referring provider and explain to them what it means. And so those different types of AI-generated findings and prioritizations require completely different workflows, and each workflow requires a particular infrastructure build where we're having new human involvement, new roles being created, expanded roles for existing staff members. And that's really the exciting part. That's one of the most exciting things of the deployment of AI that we've learned is this, the creation of these individually tailored workflow depending on the type of algorithm and the results that they are generating.
And Dr. Jose, I think you hit on something I wanted to follow on there too. So when you mentioned not only these new algorithms and workflows, can you expand, and maybe you'll do it as you walk through specifically how you're using it at University of Miami, the new roles of staff and sort of how the impact is more than just the radiologist interpreting things. And I think you started to allude to this about the staff have different functions. You might even be creating new roles or new needs for a technologist, or it could be an RA or a PIP, other people that are involved in the imaging space as well as our multidisciplinary kind of approach and different colleagues. But can you just tie into that a little bit? Because I think our listeners and especially our AHRA members will be wondering about how does it impact the technologists? How does it impact the staff that are taking his images and with the patient during this process?
Absolutely. And again, that's perhaps the most gratifying and exciting thing. And I'll share some stories on that. So number one, we're in the process of deploying a pneumothorax algorithm, and we had to create a specific workflow using our technologists and nurses and clinical coordinators to be able to successfully launch it. So as Dr. McKinney alluded to, prior to implementation of an algorithm, we sit down, we create these trial pilot programs where we're not really evaluating the efficacy of the algorithm and, let's say, diagnosing the finding. That's not what we're really interested in following. What we're interested in following is the impact and the effectiveness of the workflow in the implementation of that algorithm. So to that point, for the pneumothorax algorithm that we were deploying initially in a controlled environment to determine the efficacy of the workflow, the result has been really positive for our staff. So instead of having that hesitation of, oh my goodness, AI is going to add more work for me or AI is going to take over my job, the feedback that I'm getting from our technologists and our nurses are, this is wonderful. I'm going to start getting more engaged in helping taking care of the patient. So for us, for our pneumothorax algorithm, we're having the notification from the algorithm go directly to our X-ray technologists so that they, at the point of care, are going to be interacting with the patients, and they're going to be then starting our cascade of workflow specifically for that, where they're going to be contacting the responsible radiologist to verify the AI finding and then serving to communicate those findings to the referring provider while they're still holding on to the patient in the department. And the feedback we've gotten from the technologists in these expanded roles is exciting. So once we educate them and once they understood what their expanded role was going to be, they're really excited to do that. Similarly with our nurses, where they're going to be called to monitor the patients while they're held within our department until the imaging findings are validated and conveyed to the referring provider for final patient disposition. They are engaged. Why? Because we're expanding their traditional roles. We're empowering them. And if you remember, and it's critical, all of us involved in healthcare, the reason we got into healthcare was to help people. And anything that AI does that empowers humans to help patients and overall people further, it excites them. So it empowers them and it augments them. And that has been the feedback that we've received from our technologists just on the pneumothorax algorithm. With regards to the other critical findings of incidental pulmonary embolism or intracranial hemorrhage that we've already deployed, we've expanded the roles of our nurses and nurse practitioners where they are tasked to supervise, stabilize, and monitor our patients until those imaging findings are validated. So they are the forward-facing providers that are directly interacting with patients within our departments. They're getting to know their families. They're explaining the imaging results. And then once the referring physicians have determined the patient disposition based on the finding that has been validated by a human, those imaging findings are then conveyed to the patient via our advanced providers, and there is an easier adoption. So again, patients feel the satisfaction of knowing that they've been taken care of at that point of care. So no longer are the radiologists and the imaging department seen as these faceless people that are just putting out results, but instead, AI has empowered us to be more present in the patient's life or pathway or care journey. And that has really responded positively in the feedback. And more importantly, it has generated a tremendous sense of satisfaction in these new and exciting roles. We have our nurses, technologists, and nurse practitioners learning about AI, learning on how to interact with the different vendors. And this is vendor agnostic. The platforms we've created, the workflows we've created can be used for a multitude of vendors. So it's not vendor specific, it's finding specific, which is at the core of our deployment.
Right. I mean, that just, you hit on so many themes there. If we had, hours of time, we could delve in more details on that get me excited. Just the idea that you're helping expand or enhance, the role of a technologist and having them have a new way of interacting with patients and not just simply saying, I took an image and they don't even know the result, or, take an image and they leave. They're actually able to be interactive and there with the patient and actually see the flag that says, oh, I'm going to talk to a radiologist now and you're going to get your result more rapidly. The patients often, you get your exam, you leave, and a week and a half later, you may get a call about your results and you're nervous and you're panicky. I think what I'm hearing you say is now, in this case, specifically with the pneumothorax algorithm, a patient's going to know right then and there, and they'll have their result. And in fact, then you're working with a multidisciplinary team that's going to help them plan their next steps. So me as a patient, I get really excited about that. What a way to engage, just, enhance my experience and, expedite the care pathway so I don't have such anxiety or things of that nature. I think it sounds like a phenomenal sort of impact story that I really hope you guys continue to see those results.
And Jason, one quick other point on that. So remember, when the stories of AI came in, especially on medical imaging, there was fear and hesitation that AI was going to replace the human roles, right? And so imagine, you have someone that works in a film library that is concerned, oh my goodness, AI is going to take over my job. What we have been doing is, with the help of AI, we're transforming and expanding that person's role so that they're not being replaced, they're being augmented. And it has created a level of democratization of medicine where we're having people involved in different roles in the patient's care, having impactful interactions with patients because of AI. And so it helps us further our mission of diversity, inclusion. We're having people from everywhere, from our receptionists to our film library, to our technologists, to our nurses, at every step of the way, having meaningful interactions with expanded roles.
Yeah, Jason, if you don't mind, I want to add something. Rather than displacing or replacing radiologists or radiologist technicians or film file, there's actually been, huge potential for advancement for the people. And frankly, they all have seen it coming at whatever education level, experience level they're at. They see it coming with AI, right, Jason? So They love the
Right.
fact that, hey, guess what? I have a job that involves AI. I'm not a radiologist or even I'm not a tech, but I'm making sure that I'm dealing with the findings from AI or the data generated from AI or the patient disposition generated from AI. So that's a huge potential for, satisfaction and advancement. So retention ultimately, because we have staff, there's staffing shortages nationwide in all parts or most parts of radiology.
That's right. That's right. To me, it's almost like it helps entice people to want to continue to be a technologist or get into the field because there's just this ever-changing role that it's not just taking a picture, so to speak. Now you're really getting a chance to interact with the patient and really be part of that diagnostic experience, which I think for our technologists would be really excited about that. So I notice as we started to sort of wrap up, maybe I can just ask you guys two themes that we can hit on here is sort of, I love the phrase that we talked about in our prep work about how you're sort of almost seeing this as changing the world of radiology to preventional radiologists, right? Or a new term that sort of said this is allowing us to get out ahead of things much more aggressively than we could in the past. Maybe you can speak to that a little bit and then maybe tie into sort of where you see your next use of AI at University of Miami and just touch on a couple of those points. I think that'd be a good way to sort of take us towards the close.
Yeah, thank you. I'm going to try to do the quicker version of overall how, we see this. And maybe Dr. Jose, if you don't mind giving a couple examples that we've talked about in the past clinically. So we've started using the word, you hear about diagnostic radiologists. That's the mostly non-patient facing radiologists, that CMS term with administrators out there, right? And then versus the intervention, which are mostly patient facing, although not always radiologists, right? We kind of came up with a third term, which is the preventional radiologist, right? And we think that this is where one of the things that we wanted to end with is that preventional is identifying things that people are at risk for that it wasn't ordered for, right? So a word we're starting to use in the American College of Radiology is, as we start to try to measure impact. We talked a lot about the patient-facing part, Jason, earlier, but whether it's patient-facing or not, one of the things that we could do as radiologists on this preventional aspect is on a film that's, as CMS uses the term, reason for encounter or reason for exam, right? That's the term. Is that maybe something that wasn't in the reason for exam, we find something they're more likely to die of in the next 10 years. Like they might be negative for the tumor in the lungs or the abdomen, but guess what? We found severe coronary calcifications, right, on that. And optimizing the workflow that we, not just the radiologists, which some were trained not to even mention it, by the way, many, many, many years ago, right? Now we mention it on these CT scans. More than mention it, put in the impression, and say, let's weaponize that and make sure that patient gets to a cardiologist. So now it requires radiology to work with cardiology, cardiovascular medicine, et cetera, diabetes teams, et cetera, making sure these patients get back to their primary doctor faster and getting a dedicated workup for that condition. Another one that we think is coming down the road, now, then I'll turn over to Dr. Jose, is arterial calcifications on mammography. Much larger chance of being one of their leading causes of death in the next 10 years if we find that incidentally on a routine mammogram. So, John, I'll turn it over to you, but I think those are just some of the many possible examples of us being preventionalists, but those will, when we adopt that role, Jason, it will force us to develop, as we said earlier, workflows and some more patient-facing aspects, if not me, the radiologist myself, perhaps the HI that works with me, which are the various other people he's discussed in the cycle, advanced providers, RPAs, APPs, APRNs, et cetera. And so I think how you develop that workflow as a radiologist, how you oversee that rather than just, so be a catalyst, in other words, and not just be we don't want to become commoditized and become a victim, right? So how we kind of take ownership in that in our system and really engage the other leaders and the other services and the administrators and develop ROIs for the value streams that we're creating, like cardiovascular medicine is the example I just used, and like breast oncology as I just used an example. Developing those values together also articulates the system so we can get that buy-in and the resourcing to pay for the human intervention that we think needs to happen. So that is, that becoming a preventionalist is an investment.
Absolutely right. And one of the biggest challenges for any health system, regardless of size, in implementing AI in healthcare is what to do with the incidental findings. Because as we all know, AI is capable of making significant findings, whether they're critical or non-critical, in studies that no one was expecting to see that, right? So that's the concerning one. Who takes ownership? How are those findings conveyed to the patients and the referring providers? And more importantly, going back to our core mission, how can we better take care of our patients? Because that, in essence, is what we're here for. And to Dr. McKinney's point, the really exciting part of these preventative workflows is that we are empowering our different medical subspecialists. So it's no longer up to the Department of Radiology to determine what is going to happen with a patient, but instead we're engaging in a very forward-looking mechanism or way through teamwork where our, for example, cardiologists will say, when AI detects these incidental findings, whether it's coronary artery calcifications in a routine CT of the chest or in a mammogram or other imaging-related incidental findings moving forward, we want the radiology department to communicate with the patients, to explain to them those findings, and then this is where we want you to lead those patients. Again, we are not dictating management. Our referring providers, our subspecialists are letting us know. So in a way, it works as if a screening is in place where our most talented and educated healthcare teams for the individual findings are dictating the patient management. So whether it's cardiology, neurosurgery, endocrinology, any of the medical specialties will be pre-selecting what those incidental findings are, how they're going to be managed, what information will be conveyed to the patients, and how those patients are going to be triaged within the health system to make sure that they receive the most appropriate care. And that solves a huge problem for the institution. It creates a pathway by which there is a structure on how to handle these incidental findings that are significant, but that need to be conveyed. And so the common pathway is through the imaging department.
Right. Well, I have to say, and honestly, it's like I could talk to you guys for hours. I'm so excited to hear about an organization that is actually realizing these types of benefits. And like I said, when I started, it's not conceptual ideas, but real ways where, you guys are enhancing patient care and it's innovative, a way to interact with the patient. So better experience there. The staff are feeling the positive side of that. I love how you just wrapped there with sort of the collaboration across service lines. And let's say that we're bringing the radiologists from sort of the behind the scenes in the dark room to the front lines and like really being partners in understanding the care continuum and more than just diagnostics, but really kind of laying out the path forward. I think I get excited about that. And it makes me excited about where AI is going in the future and the different ways, just the different enhancements we're going to see in patient care and just workflows as we go forward. I thank you guys for sharing your stories. I say congrats on sort of your experiences, and hopefully as you guys progress, I'd love to, circle back and hear more about the impact you're having. I think you're setting the bar in my mind for some really fantastic strides forward. Any other closing remarks as we wrap up? But I really, really appreciated having you guys with us today.
Yeah, thank you, Jason. Sorry for interrupting you. I was just going to say, I cannot emphasize what you said enough. Working with your partners on that value. Radiologists working with cardiologists. Originally, many years ago, we're taught we're in conflict with them. They read these films, you read those films. We debate. No, work with them. It's a non-zero sum game for the patient. We all win if we do a good job and if we get the patient to where they need to go faster. They get more visits. We get more images. It's a win-win scenario if you start out with that mindset and if you work in tandem, as you just said earlier, with your other clinical leaders and administrators, and bring that value to senior leadership.
Right. Just one of those benefits of AI, like you said, that it's a little bit different than maybe where some of the vendors or partners thought AI would take us. But I feel like there's no limits here, and just excited to see what comes next.
Thank you for having us, Jason.
Yeah. So thank you, Dr. Alexander. Thank you, Dr. Jose, and more to follow.
Thank you.
Thank you.
Thanks for listening to Medical Imaging Matters, a podcast from AHRA, the Association for Medical Imaging Management. If you have enjoyed today's episode, please be sure to subscribe, rate, and review. AHRA is proud to be the trusted association for medical imaging management professionals, offering career development programs, a comprehensive selection of educational conferences and seminars, networking opportunities, award-winning publications, the certified radiology CRA credential, and so much more. To discover all AHRA has to offer, visit our website at ahra.org. Until next time.